So here is a map on the right side. I'll show you an anatomical map. And basically what you're seeing is a lot of marbled tissue, or marbled pattern. Healthy tissue's purple, the scarred low amplitude tissue is the red. So it's kind of riddled with scar on the posterior wall of the right atrium. Here's the anterior portion of the right atrium as well. So there's definitely some scarring over on the right atrium. Now on the left atrium, this is the posterior wall where we did our work. So, the posterior wall was ablated and the pulmonary veins are ablated. That's why you don't see any signal. So that's what we wanted to do last time. But what's left on the top of the left atrial roof there, again, it's this marbled appearance, which is basically riddled with scar, which can predispose to atrial fibrillation. Now again, you don't want to ablate all that because you can affect conduction. You can affect how well the atria contracts, can predispose to clot. This is just another view on the bottom. There's just a little bit of healthy tissue here at the bottom. So this is going to make it, very challenging to maintain normal rhythm going forward. Options at this point, in my opinion, that's fine. In my opinion, I don't think another procedure like a maze procedure would. I think there's more risk than benefit. I wouldn't recommend you do that. Because you could ablate more, but I don't know what there is left to ablate, and what's left outside of the usual ablation regions is scarred over. A lot of scar riddled throughout it, predisposed to AFib. So I think realistically, it's going to be medical therapy, a combination of the right medical therapy, and just addressing risk factors, being compliant with CPAP therapy. She wears the mask.
She doesn't need it. There's no.
She doesn't need it now.
She lost a lot of weight.
She lost a lot of weight. And there's no snoring or anything like that.
Okay.
She probably is due for another study.
Well, I guess if they want to, just be sure, that's good. Weight loss does help with sleep apnea, absolutely.
Yeah. Like I said, it's completely turned around.
If there's no component, great. If there still is somewhat of a component, that should be addressed. Maybe that might help the cause of, of reducing the AFib. You could start with a home sleep study, that's one option. And then another option is, so then I'll move on. So again, addressing reversible factors like sleep apnea. She's lost weight, that's great. Just keeping the weight off is a good idea, of course. But at this point, I think it's going to be medical therapy going forward, finding the right medical therapy for her. So she's on Ticastin, she's on metoprolol as well as 𝗥𝗲𝗽. It's more than a little amount of medication.
Yeah.
There's amiodarone. It's more potent than Ticastin, but she's too young to be on that long term. It can cause thyroid issues, retinal issues, lung, liver issues. So, I could talk to her about this as well. The procedure was relatively quick today because we didn't do any extensive ablation or anything like that. So I plan on discharging her home. I don't want to keep her overnight if I don't feel I really have to.
Okay.
So she's going to go up to the post-anesthesia care unit. She'll be brought back down here in about an hour. I'll come by. I put a suture in each growing. I'm just going to snip it, and then we'll see how she does and see if she can go home.
Okay.
Okay, I wish I had better news, like if I saw something definitely obvious that I could address with ablation, but really, if there was one specific focus that was an issue that was triggering it, I would have gone after it. But if there's scar scattered both sides, there's not a lot you could do. Even if I did a linear ablation line prophylactically in one spot, you're leaving other spots there that can trigger AFib. And I think at that point, ablating would carry more risk than benefit. And I don't think it would be beneficial.
And there's nothing like just a pacemaker or anything like that would be
well,
useful?
a pacemaker won't take away the AFib. People who get pacemakers for AFib, a lot of times they're much older in age, and that's if no matter what you try, the AFib's coming back. Well, sorry, the one scenario is, let's say they go into AFib, but you have to treat them with meds. But when you treat them with meds and they go back into normal rhythm, their heart rate's too slow.
Okay.
So that's one of the most common reasons. It's usually the much more elderly patient. They get a pacemaker, so you can medicate them and not worry about the AFib. Another scenario is, which may be more related to Maria, is that despite maximal tolerated medical therapy, you're getting AFib, but it's running wild all the time, and someone feels unwell. The pacemaker itself won't keep someone in normal rhythm, but it can help regulate the rate. It would help regulate the rate because if no matter what you try, the rate's fast, and you're throwing the kitchen sink at them and they feel like crap,
between the AFib and number 2, between all the meds you're giving them, you can perform what's called an AV node ablation or an AV node modification. It's a normal structure in the middle of the heart. Electricity goes from top to bottom. You purposely damage the AV node to slow conduction, but you don't have to worry about the pacemaker, the rates dropping too low because the pacemaker's there.
Okay.
But the AFib will remain, but the rates will not be fast. And
Does that affect the contractility of the heart though?
I mean, the top of the heart the bottom of the heart will contract differently now that you're going to be pacing all the time. The pacing becomes pacemaker dependent, which I try to avoid in patients as young as Maria. I try to maximize med therapy as long as I could for someone like her. That's my opinion. But if Maria wants to seek a second opinion, absolutely, I understand that, and I'm happy to give her any kind of other referrals. I know she's seen Dr. Everett in Altoona.
She did not, because the insurance didn't cover it. So
No, she saw her,
Yeah,
but
she
she
saw
wanted to refer her somewhere
Okay.
that place. But she did see her. She wants to go back and see her again. That's fine.
Okay.
But or if she wants to seek another opinion, I'm happy to give it to her.
What do you think about like some of these like AFib clinics, like Cleveland Clinic will do they'll do like a chart review. They don't see you, but you can send your information off, and then they'll do.
Yeah, it can't
they'll
hurt.
do something like that.
Sure, if she wants to do that, that can't hurt.
Okay.
Yeah. Get another set of eyes on it, I guess. See if they can offer anything in
So
that one.
she wasn't an AFib when you
No.
started, right?
No,
Yeah,
no.
because I asked her this morning, and she said she seemed all right.
Yeah.
So she's back. She's not in it now.
She was transiently in it. We shocked her out of it.
Yeah.
She's leaving the
Okay.
lab now in normal rhythm.
Okay, cool.
Yeah. I wish I could have done more for her today, but this is one of the tough cases. I mean, I have to treat a lot of AFib. Maria's only the one in a few, if the handful, that it's just been really hard to control post-ablation with the back wall.
She can go, like a couple weeks and she's fine, and then it just bounces out.
Yeah, unfortunately, I know she struggles when she's in it, but it really comes down to quality of life. If she's really struggling with quality of life, I recommend she could seek another opinion to see if they can offer anything else. But right now, honestly, if it were my family member, loved one, I'd try medical therapy, try to maximize as much as possible for as long as possible, and avoid a device implant. So.
Yeah, I'm no doctor, but I feel that it's kind of stress related. You know what I mean?
Yeah, and stress, physical, emotional stress can trigger it. Definitely, there's neuro input to the heart, and one of those two things can trigger it. But if you can tell me how to avoid stress, call me, okay?
Right. Yeah. Right. I
And
understand
sometimes
that,
it's
but
unavoidable.
She's just high strung sometimes.
Sure,
you know what I
sure.
mean? She
Yeah.
needs something to
Yeah.
take the edge off.
Well, yeah, I mean, if that can be addressed in some way, I would recommend she double checks if for the presence of sleep apnea. Really, if you really want to keep
She
her in
probably
normal
needs
rhythm.
another sleep study.
And then
Wouldn't we notice the snoring or the?
sometimes snoring's apparent, sometimes not.
Yeah, because it used to be really bad.
Yeah,
And-
you hear it at all now?
No.
Okay, there might not be, but honestly, if we're trying to deal with this and make them feel better, I'd probably just take that extra precaution, make sure it's not there with the study. Yeah, that's my opinion.
Okay.
All right.
Thank you.
Sure.
Okay, yep.
Take
Can we
care.
go see her when
Okay.
she gets up there?
Yeah, when they bring her back down, they'll tuck her into a holding bay, and then they'll let you know when she's down here.
Okay.
Okay.
Great.
All right.
Appreciate
Yep.
you.
You're
Thank
welcome.
you.
Have a great
See ya.
day.
You too.